Good evening. My name is Susan Holzman, and I am the president and CEO of NAMI Miami-Dade County. And I'm very excited to welcome everyone here this evening for this amazing presentation that we have. Many of you have attended our regular monthly presentations, and we have great participation, and we're grateful for that. This month is special because we're using this presentation as our kickoff for our Pathways to Hope conference, which is coming up in August. So I'm going to hand the microphone, the camera, the screen over to Sherrod Johnson, our Director of Outreach and Communications, to give to you a little information and introduction to the Pathways to Hope conference before our speaker gets started. Sherrod, go ahead.
Good evening, everyone, and welcome. Thank you so much for logging on. This is our kickoff to our Pathways to Hope conference. And for those of you who may have just been hearing about Pathways to Hope is an opportunity for faith communities to connect with those networking with mental health services. NAMI National started not robbery, but thought it would be a way for those who feel as though their faith leaders are their first connection dealing with mental health. This conference is a time that I call it the People's Conference. This is the time that we come together, we learn about the resources in our communities, and we actually hear your voices. This is the time, this year, the theme is called Navigating Healing in an Unchanging World. So many things are going on in our world today, and we want to make sure that everyone has access, resources, and information. So please do not miss this opportunity. Friday, August 21st, and Saturday, August 22nd, at the Little Haiti Cultural Arts Center. I hope to see you there. And back to you, Susan.
Thank you so much, Sherrod. The video that we showed at the beginning was mostly pictures from last year's Pathways to Hope, and I think some even from the year before. So it's a great day to come. We gather faith leaders from all over 2 counties, from every faith community, to talk about their experience really as first responders in mental health. And then we bring in providers. So last year, our keynote speaker was Dr. Edward Suarez, and he is a great friend to NAMI, a great friend to us. So let me just give my little full introduction for Dr. Suarez. He's a research associate professor at the University of Miami School of Medicine and program director of the Idea Exchange, Miami-Dade County's Syringe Services Program and Low Barrier Behavioral Health Clinic. He also serves as an attending psychologist with UHealth Jackson Health System and holds a secondary faculty appointment in the Department of Medicine. Dr. Suarez is a licensed mental health counselor, licensed psychologist, researcher, and healthcare administrator with extensive experience in community psychiatry, substance use disorders, harm reduction, HIV prevention, and implementation science. His clinical and research work focuses on expanding access to evidence-based behavioral health services for underserved populations, including individuals living with serious mental illness, substance use disorders, homelessness, and other social and structural vulnerabilities. As a clinician, educator, and mentor, Dr. Suarez is dedicated to training the next generation of healthcare professionals and advancing innovative models of integrated care that promote recovery, resilience, and wellness. His work has been recognized through numerous scholarly publications, conference presentations, and community partnerships aimed at improving public health outcomes and reducing health disparities. Dr. Suarez is passionate about fostering compassionate, person-centered care and strengthening collaborations between healthcare providers, community organizations like ours, and individuals with lived experience to improve the lives of those affected by mental illness and substance use disorders. So I want to start off by saying thank you, Dr. Suarez, for everything that you do and for always being available to us at NAMI, and for being just so approachable and so down to earth. So now this presentation that you're going to give is going to connect us with the clinical issues in mental health and those issues of faith. And so thank you, Dr. Suarez.
Thank you so much, Susan. That was a really great intro. I loved it. It's very long. I can't believe I've been at this for so long. Amazing. It's always an honor. And then let me share my screen. I was supposed to do that while you were talking. I'm a little behind already. And here we are. Okay. And so, as Susan said, I go by Eddie, but Dr. Suarez is definitely whatever. And before any of these, I like to start with this. Before any of these acronyms were behind my name, I was a clinician in the intensive outpatient program at a community mental health center in Seattle, Washington. And I was out there pretty much alone because I'm born and raised down here in Miami. And I went to Seattle to go see what it was like out there and to pursue a doctorate. And I got this little job at a community mental health center. And one of my patients who was living with schizophrenia, and he was fairly stable. We were the same age. And he invited me to the NAMI house in Ballard in Seattle, Washington, a little suburb called Ballard. So I think it was called the NAMI Ballard House. And there, me and the young man I was taking care of, and his mom was also there. I was introduced to NAMI, and just this camaraderie and this beautiful, joyous community of moms and dads and brothers and sisters. It just amazing camaraderie. And so to bring it back full circle and to give this talk for NAMI, it means a lot to me. And NAMI played a big role in my life because out there in Seattle, I had my classmates, I had a few friends, but I was alone out there. And so going to that NAMI house with my patient as outreach every now and again through the community mental health center, it was really awesome and uplifting for me, and it's amazing. And I wanted to start with that. So moving to the next slide. So the last time I presented this for the keynote, which was awesome, the people in the audience, there were many first responders there. And then I thought to myself, in a way, when it comes to mental health, we're all first responders because we never know when this is going to cross our face, and we're going to have to react, right? So what I want to use this slide for is to do two things. First, I want to give you a definition of what I do more or less when I'm at work. It's this thing called community psychiatry, which is a branch of psychiatry focused on the detection, prevention, and treatment of mental disorders in the community setting. And this all came to be because of these moments in history. And I think what I'm trying to say is that when you look back at history and you realize that it's really difficult to manage mental health issues in Florida specifically, and in the nation, it's because of the way things rolled out regarding public health in the past. So back in the 60s, and I'm not trying to blame JFK for anything, but we had the Community Mental Health Act of 1963, and this became known as a deinstitutionalization movement. And this is how we got community mental health centers like the one I worked at in Seattle, Washington, as I was saying. And from that deinstitutionalization movement, those who were housed in psychiatric facilities were released back or discharged back into the community. But at the time, there was no infrastructure for people with severe mental illness to be cared for the most part. And it just didn't really work out the way they thought it would. And so here we are in 2026, and we're kind of picking up the pieces still to this day of, I don't want to call it failed implementation, but we're picking up the pieces. I'll leave it at that. And somehow along the way, police officers became the first responders for mental health crises. Interesting, right? And psychiatric hospitals kind of became standalone institutions where you kind of have to get the person there. And it's just interesting to me that although in 2026 we're dealing with a lot right now because of the way things are shaken out, especially when it comes to healthcare in this nation, it's just interesting that we're still picking up the pieces, I said, from that 1960s. Sorry to repeat myself so much. I'm just trying to make sure I keep it PC. But it's a bit of a mess, and I'm here to fix it every day. That's kind of what I'm trying to say. And each of you play your own role every time you come to a NAMI meeting, every time you support a person with mental illness. You're doing your best to make this community a better place, and I will always thank you for that, right? And so this presentation is about faith, mental health, and the brain. right? And so, speaking of faith, I pulled from the Abrahamic religions to kind of give you this idea of taking care of others and how you can find this in the Talmud or the Quran or the Bible. And I don't want this to be death by PowerPoint, but if you could allow me to read these, I would really appreciate it. So Matthew 25, 35 to 40. For I was hungry and you gave me something to eat. I was thirsty and you gave me something to drink. I was a stranger and you invited me in. I needed clothes and you clothed me. I was sick and you looked after me. I was in prison and you came to visit me. Then the righteous will answer him, Lord, when did we see you hungry and feed you, or thirsty and give you something to drink? When did we see you a stranger and invite you in need, or needing clothes and clothe you? When did we see you sick or in prison and go to visit you? The king will reply, truly I tell you, whatever you did for one of the least of these brothers and sisters of mine, you did for me. And then going to the Talmud Nadarim, whoever visits the sick causes the person to live, and whoever does not visit the sick causes the person to die. Then moving to the Quran, righteousness is not that you turn your faces toward the east or the west, but true righteousness is in one who believes in Allah, the last day, the angels, the book, and the prophets, and gives wealth in spite of love for it to relatives, orphans, the needy, the traveler, those who ask for help, and for freeing slaves, and who establishes prayer and gives zakah, those who fulfill their promise when they promise, and those who are patient in poverty and hardship. Those are the ones who have been true, and it is those who are the righteous. So since the beginning of our civilization, we've had books on our tables that give us the blueprint for making this a better world. And yet we get so stuck in our own heads. We want power, we want fame, we want it all. And we start stepping over people because of it. And so a lot of this presentation today is for me to bring you back to the values of compassion, to the values of love and healing, so that you can spread this across the world in the best way you know how. And again, it's an honor to be here, and I hope we can do this together. So one thing I wanted to start with is, I'm assuming many of you are watching this on your phone. So you can screenshot this QR code and figure out a way to take a picture of it later, or go to the Self-Compassion website. But if you could take a picture of this QR code, what will pop up is a survey that identifies how compassionate you are with yourself. Because let me tell you something, guys. We will say meaner things to ourselves than we would ever say to another person. And so if your internal dialogue has a body count of 1, you need to check in with yourself, and you need to find time to be kind to yourself. Because if we are not able to show ourselves love, it is difficult to show love to others. So I not right now, because I need you guys to pay attention to me, if that's okay. But when you have the opportunity, please fill out the self-compassion scale and see where you land on it. Once upon a time, I did it. I haven't done it in a while. My last time, I guess, was January 15th, 2025 at 6:38 a.m. Wow, I was up early. But my overall score was 4.12. So what was a note there? Note, average overall self-compassion scores tend to be around 3.0 on this 1 to 5 scale. So you can interpret your overall scale accordingly as a rough guide. 1 to 2.5, you're low in self-compassion. 2.5 to 3.5, you're moderate. 3.5 to 5 means it's relatively high. I guess I did mine on a good day. And then there's subscale scores: self-kindness, common humanity, mindfulness, self-judgment, isolation, over-identification. These are components and attributes that can get in the way of our functioning and being what we need to be for other people. So the other thing I'll read, and all this will come when you finish your survey, you'll see this on your page as well, but remember that higher scores for the self-judgment, isolation, and over-identification subscales indicate less self-compassion, while lower scores on these dimensions are indicative of more self-compassion. right? So just keep that in mind if and when you take your own self-compassion test. And then moving forward, again, as Susan said, I primarily work with the sick and the poor, and it's an honor to do so. And my friend Brett Feldman, who's a professor at the University of Southern California and leads the street medicine department division of street medicine for USC out there in LA, he kind of taught me this, and I want to share it with you. The spirit within our vulnerable populations, right? Because it doesn't mean you're homeless. Like once you're living with severe mental illness, once you're living with a substance use disorder, your vulnerability index has increased. And I see the world through a vulnerability index. I really do. And I try my best to help people either prevent or manage these vulnerabilities. But the spirit within our vulnerable populations, imagine being a spirit inside of a body that is not wanted anywhere. To bring you into my world a little bit, we have politics happening where it's pretty much illegal to be homeless now, right? And it's very sad. But we pivot and we adapt and we do what we can to help others. But in this idea of being a spirit in a body that is not wanted anywhere, it's a reality for people with severe mental illness, severe substance use disorders, and often for those living on the streets. So when you go on your journey, please remember this, that you're dealing with vulnerable spirits and that we must do our best to lift them up and fill them with hope. Because after all, Shara said this is the people's conference, and it's up to you all to be the people's champion. Only you can do that. And you can instill that championship within them, right? That champion nature within them so they can grow on their own. But sometimes these things start from the outside. Sometimes you have to believe in the patient more than they believe in themselves for a little bit. And then they'll catch up sooner or later because you feed them hope, not false hope, but hope that things can be changed, can be different. So moving on, and I hope I'm not going too quick. I'm trying to not speak too fast, but one of my heroes, he was a psychologist named Carl Rogers. He started person-centered counseling, person-centered therapy, whatever you want to call it. And it is something that I make sure my staff at IDEA and the residents that I have the opportunity to train and things that they understand who Carl Rogers is and this idea of unconditional positive regard, right? So this unconditional positive regard, which I'll call UPR moving forward to save time, but it refers to acceptance of the worth of the person, not acceptance or approval of all behaviors. UPR allows professionals to connect with people on a human level, build rapport, and diffuse difficult situations through empathy, which we'll talk more about that later, patience, and acceptance, even if sometimes that acceptance has to be radical. So sometimes you do have to practice radical acceptance, which comes to us from another therapy called dialectical behavior therapy, which I don't talk about that today, but anyways, just, I don't know, I'm getting tangential, but unconditional positive regard, remember this. So this approach not only improves the client-professional relationship, but also increases the likelihood of better outcomes and improved client satisfaction. So take a peek at that Venn diagram. You got empathy, you got acceptance, and you have support. And in the middle of that Venn diagram, bringing everything together is this idea of unconditional positive regard. So this idea of acceptance without judgment, right? When persons exhibit difficult behaviors, I see it all the time, and it is what it is, guys, right? Aggression, frustration, they're not taking their meds, a psychiatric pitfall occurs, they're hearing voices again, it's getting harder to communicate with them because of this. You know, there's confusion, it's easy to feel frustrated or irritated. Well, UPR encourages professionals to resist the urge to judge the person or their actions and instead to offer acceptance and understanding. For example, if a person is being angry or hostile, try not to respond with defensiveness. You would use UPR and you might acknowledge the patient's feelings by saying, I can see you're upset and I want to understand what's going on. I want to hear you out. Something's on your mind that's upsetting you. Let me hear you out. Let me see if I can help you figure out what's going on. Something along those lines. Because as you can see from the little cartoon, your mind judges every experience. It's either good, it's either bad, it's either neutral. And I'm here and often I try to say the stimulation that happens in front of us is merely stimulation until our brain interprets it. And so if we can convince ourselves that the things that happen in front of us, as bizarre as they are, as harsh as they are, as good as they are, that it's nothing more than stimulation until my brain interprets it as good, bad, or neutral, that's practicing mindfulness. And practicing mindfulness, along with gratitude, is a protective factor which helps decrease the likelihood of acquiring anxious and depressive episodes. So the more grateful you are and the more mindful you are, you give yourself the objectivity to find the good and the silver lining, and you could always cognitively redirect yourself to think more in the positive. I am a temperamental hothead. I am compassionate. I have Cuban blood, and sometimes you'll see me out there ripping and roaring. And even I myself have to stand back and be like, you know what? Today, God gave me breath in my lungs, and that's all I need right now. And I gotta keep moving forward, right? I will self-disclose as I go because just like all of you, I might have a bunch of acronyms after my name, but I'm just human. And I'm guilty of being alive every day that I wake up, and I do my best to atone for that. But anyways, empathy and active listening, right? A key aspect of UPR is to listen actively and empathetically to the person's concern, even if they're difficult to manage. Active listening involves paying close attention to both the words and underlying emotions of the person. This communicates that their thoughts and feelings are valued, which can help to diffuse the tension. Empathy involves understanding the person's perspective, even if you don't agree with it or fully understand why they are acting the way they are. So in this figure that I placed here, practicing empathy and active listening, put aside your own biases and judgment, right? I'm an intern from the Department of Corrections out there in Washington State, as well as that community mental health center job. I had to do evaluations on guys that did some pretty disgusting things in this world, but I had to put away my biases and judgments and do my psychological evaluation and see these guys for therapy and see them for group and see if I could actually help rehabilitate them, right? Along that pathway, I had to listen actively. To the best of my ability, I had to show some empathy so that they could learn what empathy actually is supposed to look like. Then I had to avoid interrupting, which is really difficult for me. There's a few of my friends on this phone call or this Zoom, and they know how impulsive I am, and it's very difficult sometimes for me to bring it back and not interrupt because I am so solution focused and I just want people to get better. But I always have to remember that the person I'm seeing for help, they're the expert in the room, and they're the one who needs my time. And so my time sometimes has to be silent time, and that's actually good for me. And then this idea of practicing reflection so that you can validate them and that they feel that you've understood what they're saying. And sometimes that's as easy as I hear what you're saying. So again, going back to my years in Seattle in grad school, I one time stumbled upon Bruce Lee's dojo, having no idea that he lived there. And I kind of loved that. And I went down a Bruce Lee rabbit hole. And he has so many great cliches and sayings that I'm only using one today, but wow, that guy was the man, let me tell you. And one thing that I'll put up here is this idea of non-defensiveness and calmness. So when a person behaves in a difficult or challenging manner, such as being uncooperative or irritable, you might feel defensive. But responding defensively can escalate the situation. By adopting UPR, the professional can remain calm and not take the person's behavior personally. Instead of reacting with frustration, they maintain a calm, reassuring tone and demeanor, which can help to create a safer space for the patient. For many of you, I'm going to assume things. I'm talking to clinicians, peers, family members of those living with mental illness, things of that sort, and to remain calm and be able to work through the frustration of a person, it really does build safety. And sometimes because some of us here are professionals, on our worst day, we might be the best they're going to get. And it's important to remember that. So empty your mind and be formless, shapeless like water. Now you put water in a cup, it becomes a cup. You put water into a bottle, it becomes a bottle. You put it in a teapot, it becomes a teapot. Now water can flow or it can crash. Be water, my friend. So this idea of creating a safe space, difficult people often act out of fear, pain, anxiety, frustration. In the last, 20 years, we've had the trauma-informed care initiative so that we hopefully are training people to be more mindful of people's traumas to the point of generational trauma and understanding that as we learn more about the science of trauma, that trauma does stay in your genes and there are genetic markers of trauma in all of us. And so offering UPR, professionals can create that environment where the person feels safe to express their feelings, whether they are positive or negative. And this can increase trust between the person and professional team, and it improves cooperation in the long run. So again, safe spaces require that we appreciate and respect the vulnerability of others and grace it with our own so that we validate their journey and we say, you're the expert of your experiences. I believe that. Let me see how I can help you the way you want to be helped, right? So maintaining professionalism without condemnation, that's a whole bag, right? Because sometimes we feel burnt out. And then again, once upon a time, I wrote a dissertation to graduate. I had to write a dissertation, obviously, and it was on burnout. And so burnout happens in 3 phases: emotional exhaustion, depersonalization, and lack of personal accomplishment. Once you feel emotionally exhausted, the smallest favor feels like the biggest ask in the world, right? And that's an indicator that you're probably emotionally exhausted and you should take time off. And the other thing is amazing, right? They do all these burnout studies and a lot of funding goes in, well, not anymore, but funding went into this and all that. And I think the common denominator here is that if you feel burnt out, do your best to take some time away. The best way you can, whatever's allotted to you, you got to separate from the stimulation for a bit. And if you're unable to separate from the stimulation, then you practice mindfulness, you get in with a therapist, you exercise, right? And I know I'm going many different directions with this idea of exercise. If I can exercise my body and sweat and go, right, in a healthy way, right? I stress my body out in a healthy way. When a stressor comes while I'm at work that I'm not expecting, and I've been exercising and stressing my body out in a healthy way, I'm at work, the stressor comes, guess what? I'm better able to manage this stressor that's coming to me because I'm physiologically prepared, because I've been jogging or doing my push-ups or jump ropes. I recommend jump roping to everybody, high intensity interval training. As I say this out loud, I need to practice what I preach. I'm behind on my exercise. I'm just blessed with the skinny kid genetics, I guess, but I too need to get back in the gym. So anyways, I got tangential on you guys with all my little tidbits, but this idea of kindness, right? So we try to inspire, empower, act, reflect, and share. And a person's behavior is not seen as a reflection of their worth, okay, or dignity as a person. Every human body on this earth is worth something to someone out there, right? So this idea of facilitating positive change by providing consistent acceptance and support, UPR can foster a sense of self-worth in people, even those who may be feeling vulnerable or agitated. So this idea of uniform, as you can, like, I look to the left while I say this, the ununiformed optimism, this is the initial exciting phase where a person eagerly anticipates a desired change, focusing on the potential benefits and often holding an over-optimistic view of the process, right? The honeymoon phase, informed pessimism. The honeymoon ends as reality sets in and the challenges and difficulties of change become apparent. The individual realizes the change is not as simple or as easy as initially thought, right? So when you're trying to help people follow the positive change cycle, understands that there's levels to this, as the kids say, right? There's levels to this. The valley of despair, also known as hopeful realism, or a dip in the cycle. This is a critical stage where individuals may feel discouraged and overwhelmed by the reality of change, sometimes leading to a decision to revert to the familiar. So this is sometimes where we'll see a relapse if somebody's living with substance use disorder. Informed optimism, After working through the difficulties and accepting the reality, a sense of realistic hope and potential begins to reassert itself, now tinged with a deeper understanding of the process. Then you have completion. The individual reaches a steady and workable state where the new ways of being are integrated. This leads to increased effectiveness, happiness, and the achievement of their potential. All right. And then that third bullet point, acknowledging a person's difficulties without labeling them as difficult or bad can help them feel more in control and motivated to work on their health, by the way. So understanding context is huge. This is why active listening skills are very important. When people exhibit challenging behaviors, you recognize that their actions may stem from external factors like the ones previously mentioned in another slide, but pain, confusion, lack of understanding, negative healthcare experiences, right? UPR, again, encourages understanding the broader context in which the person is acting rather than simply reacting to surface level behavior. UPR asks you to be a deep thinker and to understand and almost have foresight in a way. And so this idea of empathy for me at a psych hospital, at IDEA, on the streets, it has to be fast. It's in a fast-paced world, right? So there's different forms of empathy according to Ross and their colleagues, but there's natural to deliberate, there's collaborative and interventional, and some on this spectrum you have relational empathy, open understanding of the patient, responding empathetically, patient narrative construction. Then you got this idea of transactional empathy, negotiation of treatment goals, negotiation of treatment control, negotiation of narrative of illness and understanding of reality. It's starting to get a little bit more clinical. With relational empathy, it's like, hey, what's up? I want to help you. My name's Eddie. How can I be the best that you need right now? All that, and I get to know you. Then transactional empathy is like, hey, because I know you now and I want to help you better, like we got to come up with some treatment plan goals. Then this idea of instrumental empathy. So understanding patient behavior and affect, managing one's reactions to the patients, right? Ain't nothing like transferring and countertransference to keep Sigmund Freud relevant to this day. And then guidance of the patient. I hope I explained that well, you guys. I know I'm going fast. So here we go. The nitty-gritty on neuroscience and mental health. So understanding the brain's role in healing. So trauma affects key areas of the brain, such as the amygdala, which is known as the lizard brain. That's your flight or fight, right? Your hippocampus, your prefrontal cortex, which is in charge of regulating emotions and decision-making. Your hippocampus stores traumatic memories. Well, it stores all your memories, but if they're traumatic, it's definitely going to store that. And again, the amygdala is the fight or flight response. And understanding these areas help us support healing through both clinical and spiritual approaches. So stress on the brain. Chronic stress can lead to overactivation of the amygdala and the shrinkage of the hippocampus. That's not good because that impacts our functioning. So our memory is poor, our emotional regulation is not doing too well, and our resilience isn't where it should be. Faith practices like prayer and meditation can help reduce stress and promote brain health. And then here's this idea from the annals of public health, right? I was talking to you guys about burnout. Well, there's this other term that's like the academic public health version of this idea of burnout, understanding allostatic load. So allostatic load refers to the cumulative wear and tear on the body and brain from chronic stress. It results from repeated cycles of stress response without adequate recovery. Over time, it can lead to physical and mental health issues like anxiety, depression, hypertension due to cortisol increasing all the time, and even immune dysfunction, right? Like flare-ups. What am I thinking of? The rashes people get, oh my goodness, and you got to take medicine for it. Wow, I can't think of it right now. My goodness, when you have the patches of red on your skin. Oh my God, it escapes me. Whatever. Relevance for leaders. Clergy and chaplains recognize signs of chronic stress in congregants and offer spiritual and emotional support, right? So if you're a clergy or a chaplain, these are the things you're looking for. In law enforcement, understand behavioral impacts of stress and trauma in community interactions. Community leaders, shingles, that's the word I was looking for. Community leaders promote environments that reduce stress and support resilience, right? So Try to understand this allostatic load, or as it's called here, aka bucket of inflammation. So low dietary quality, social isolation, which by the way, guys, we are living in an epidemic of loneliness right now, by the way. Although everyone's connected with one of these in their hands, people are very lonely to the point that our former Surgeon General wrote a book called Together, Vivek Murthy, and it's about the epidemic of loneliness. And if I am correct in this, I think it published before the pandemic, which shows how ahead of the game Dr. Murthy is. But anyways, allostatic load, just be aware of it, be kind to yourself. The other thing, this idea of a threshold for distress, because distress is what makes this happen, right? So try your best every day. I'm going to do this too. I'm talking to myself. My window of distress every day it's a large one. Every day it's a large one. And then if I feel that throughout the day, my window is getting smaller and smaller, I got to check in with myself, because if my window for distress becomes a peephole on a door, that ain't good. I'm not going to be able to help anybody if my window of distress is as small as a peephole, right? So I got to keep my window of distress big so that I'm able to help people in their distressful moments, right? But healing neuroplasticity, to stick with the neuroscience, neuroplasticity, as many of you know, is this idea of malleability. It's the brain's ability to reorganize and form new connections. Healing is possible through therapy, spiritual support, and community care. Faith-based environments can foster safety, hope, and positive change. And this was from an MRI or PET scan of images during meditation. And the reason I show this is because meditation is prayer. When we pray, we are meditating, right? And so if you look at where those arrows are pointing, look at the baseline on the left. That's the frontal lobe. Your frontal lobe, as I said, your prefrontal cortex in there, that's in charge of your executive functioning. That's in charge, that's the thing in your brain that says, hey, do this or do not do this, right? Do that or don't do that. And it's in charge of your good decision making. And it usually keeps you from making bad decisions. And so if you look at the baseline, it's active for sure, but it's not as active as in the frontal lobe of the person who's meditating in the scanning machine. And the other thing that I find fascinating, which I have to review the article again to see if it's justified, because I don't want to just speak nonsense, but it's not. Listen to this. What's fascinating is that the activity here is connected. So look at that. When we say we're connecting to a higher power, look at that brain under meditation. Look how the lobes are connecting as opposed to baseline. That is fascinating to me. And back there, you have your hippocampus is in the back all red there, and everything that I just said kind of get hurt when we're going through a lot of stress can get a little bit healed when we're able to pray and meditate, right? So the psychology of prayer. Research suggests that prayer may help reduce stress, anxiety, and negative emotions. It often serves as a coping strategy by fostering a sense of connection to a higher power, offering emotional support, and enhancing feelings of control, especially during difficult times. In the study, Prayer and its Relation to Cognitive Processes, the researchers explain that prayer engages in a broad array of cognitive functions such as perception, language, inner speech, emotions, self-awareness, memory, decision-making, planning, and social understanding. Through prayer, individuals seek a connection to something greater than themselves. Research indicates that this practice can activate psychological mechanisms that promote well-being, such as providing a sense of structure, meaning, and hope. Prayer may be beneficial by influencing how people perceive and respond to stressful situations. Check this out. Whatever we're praying for may not change, but we change. Our actions, decisions, and responses are effective. So again, whatever we're praying for may not change, but in prayer, we change. And I think that's very powerful. So in Evangelical and Beyond, this other author, just because something is abstract doesn't mean it can't have real meanings and consequences, right? Because for the most part, our thoughts are kind of abstract. They're just, it's all just chemicals and it's all just electricity and chemistry up here, guys. So feelings, thoughts, and sensations, all these things are physical reactions to chemical processes in our bodies, but they create an infinite interior space we call consciousness. We possess the ability to shape our inner world, and when we align our thoughts and use prayer as a tool for coping and well-being, we engage in a deeply empowering practice. And sometimes we pray for things that, and it's difficult for us, right? But my mom brought me up on this saying, which I live with it always. My mom taught me this. The difficult takes time. The impossible takes a little longer. So just understand that as long as you believe, you will be able to accomplish that which you pursue. So for clergy and chaplains, use neuroscience-informed language to explain spiritual healing, recognize signs of trauma and stress in congregants and refer appropriately, incorporate mindfulness and trauma-informed care into pastoral counseling. For law enforcement, understand how trauma affects behavior and decision-making, use de-escalation techniques that align with both psychological and spiritual principles, partner with faith leaders. Like that, I see that around Jackson often. I think it's beautiful in so many ways. To support community healing after crises. For community leaders, you got to promote programs that integrate mental health education with spiritual support. It's big. And you got to create safe spaces where people can share both emotional and spiritual struggles. And advocate for policies that respect both scientific and faith-based approaches to wellness, right? And oh, I guess I'm done. Here are my references. I am an academic after all. And thank you to NAMI for everything you do. Thank you all for being here. I hope you guys enjoy the rest of the evening. I hope we learned something that I was able to disseminate good, valuable information to you. And I will now stop sharing my screen.
Wow. Thank you so much, Dr. Eddie. That is how I refer to Dr. Eddie. That second to last slide, that basically was our Pathways to Hope conference in a nutshell. So we really appreciate that. I'm sure that there are plenty of questions. We had a few come up while you were speaking. But anyone who has questions, please go ahead and put them in the chat, and then I'll go ahead and ask the questions. And we got some great comments. God bless you. This is my first time.
I love that psoriasis, eczema, hives. You guys are all
everybody
yes,
was all over that.
That's
I
awesome.
get hives. I get hives, completely from stress. So there was a question all the way back at the beginning about the let me see here, about the person asked the question about the scale, about the
self-compassion scale.
Yeah. Are the subscale scores related to the Big Five?
Oh, yeah, the Big Five personality assessment. I'm all over that. There's overlap, but they are not. They're not. They're mutually exclusive, but I believe that Christine Neff, when she created this, that she did lean on the personality scales a bit. But I don't want to, this is a public forum, and I don't really want to say things I don't know, but I think it's mutually exclusive in that it's its own thing, the self-compassion test, but it is definitely from the foundation of the Big Five personality test.
Oh, can we have access to the references? Hi,
Sure.
Hi, Pastor Roll. Yes, we will get that to you. And we will have a video of this posted online, probably not until next week, but we will have that. So please include service providers, educators in the list of service providers targeted by Pathways to Hope Conference. Another group that has been pointed out to us that fits within that list would be funeral directors, who are often serving in the capacity sort of front line when it comes to mental health conditions. Is there any resources for assistance, contacts, email, and phone numbers? Right, we're putting NAMI information on the screen, and I think As far as the IDEA program, could we have some information about that and how people
Yeah.
can?
Okay, yeah, so the IDEA program, IDEA stands for the Infectious Disease Elimination Act. It was brought to be for people who inject drugs to try to keep them from acquiring HIV or hepatitis C, and then beyond helping distribute new syringes to those who need them. We also get them in care for HIV. We also cure their hepatitis C. We also, get them into recovery as I speak to you right now because we're all part of the same cloth here, guys. I have somebody at the Thriving Minds residential treatment centers, like New Hope, Better Way, I got somebody everywhere, and when it
Mhm.
comes to residential treatment. And so yeah, the idea specifically for the community outside of this, people who are injecting substances and those with severe substance use disorders, we're now under Thriving Minds, the managing entity. And so I'm very proud of that we're now with Thriving Minds. And through that, we're able to help more people with opioid use disorders. So if it's just, the thing is, and I'm not making excuses, we're five shipping containers on the corner of 17th Street and 7th Avenue across the street from Camilla's house. We ain't much, but you don't need much to change the world, right? But yeah, if you have somebody living with opioid use disorder and you think they need help, you can Google Idea Exchange and call the main line, and I or one of my colleagues will figure it out. We'll figure it out.
And I think I just want to share that's really important information. We have referred people there, and as you can probably tell just from the way Dr. Eddy approaches this, is if you have an opiate use disorder, there's probably a co-occurring, there may be another co-occurring condition. So all of that is treated. There is access to Suboxone for people who may need that. So if you are interacting with a person that needs that kind of help and it is unavailable to them, that's a really important, I think, point of access. Is that safe
That
and accurate to say, Eddie?
Susan, I think you did a better job than I did. Oh
Okay.
my goodness. And then the other thing is that at Jackson Behavioral, we have the Matter program, and we just started an addiction psychiatry fellowship program. So now we have two fellows that are training with us. And so
Oh,
Jackson
wow.
Behavioral is that's another one where I would go first to Jackson Behavioral. If it doesn't work out there, then call Idea, truly. And I
Okay.
can truly, and then because it's like it's new, it's hot. We got the fellows just started. Everybody's motivated. Not to say we're not motivated. I'm just thinking there's more resources here, guys. And so the number I'll put it here. I'll put it here. The number
Okay.
for the MAT clinic at Jackson Behavioral
Oh,
is
fantastic.
is 305-355 7105. Boom, in the chat.
Okay, that is great information. So another question that I had was the image of the brain that you showed during the baseline and then during meditation. That was the one Shara was waiting for. We love that image.
Yeah,
So, but what I noticed on that, and obviously I am not a clinician, but the entire brain seemed more lit up,
correct.
all right, all across the board. So what was interesting to me is every area was more activated during that. So it's not, like, although I guess that's really important, the frontal lobe to be activated, but that whole connection of the brain working together,
Right. And it's Susan, the thing about that is that mental health disorders happen because of two things: hyperactivation or hypoactivation, right? You have too much or you have too little, right? So you
hmm
have too little of what? Serotonin, you're going to be depressed. A little too much dopamine, you might start hearing voices, right? And it's interesting to me when I look at that scan, it's this natural meditation, prayer, whatever, is this natural way to activate the full brain and bring a balance activation, right? And because I think when something's hypo or something's hyper, the idea is to bring it back to balance. And I think meditation and prayer truly does help the brain get back to balance. And I think that's why I put that up there.
And then, so if you integrate that with, for example, you talked about the importance of exercise. So a walking meditation or singing
Oh
during
man.
a worship.
That's where it's at. If everybody was in a tube, if everybody was in an MRI at that time, it'd look amazing.
Really? Okay.
Yeah. Yeah, but that's where it's at.
Okay, we're reading this. Do you see that question?
Yeah, the most
Okay.
helpful interventions for those with addiction and mental health, you lean like as you start going, because I was in your shoes once as a Psy.D trainee. I really think now motivational interviewing is really big because let me start over. You first have to understand the trans theoretical model of change, right? That's the one that says you're pre-contemplative, you're not ready to change. You're contemplative, you're contemplating change. Then you take action, right? And when you learn the trans theoretical model of change and people's where you can gauge them in their potential to change, motivational interviewing has specific interventions that go alongside where you're at along the change spectrum of the trans theoretical change thing, right? I don't know if I explained that well. So if somebody's pre-contemplative, meaning they don't want to change at all, that's okay. Build rapport with that person. But MI or motivational interview asks us as clinicians to do conscious raising questions. So if you're in front of me and you're experiencing homelessness and you're like, I'm good with all this, all I need is my bottle of Skull vodka, like I don't need anything. I'm like, oh, that's good, man. Like I get it. I'm cool with that. But I walk down here a lot and I noticed that like you haven't had shoes on for a while. Like, maybe I can help you get shoes. And in that person might go, damn, this guy's right. I've been walking around barefoot in the streets of Miami. Like what am I doing, man? But I'm doing is offering a pair of shoes, but I'm using motivational interviewing in there to raise your consciousness to be like, buddy, it is abnormal to walk around without shoes. You ain't Tarzan, you know? Teach their own, obviously, walk without shoes. I get it, but you know what I mean? So
Okay, now hi, Claudia from NAMI, Texas, wants to know how she can get in touch with you because they need your help in Texas, and so she'd love to have a presentation.
oh yeah.
Claudia, we'll get that to you. We'll be happy to get that to you. I'm just thrilled that NAMI, Texas is on here and listening. But as many of you know, we are nationwide NAMI, so we all share this kind of information in our grapevines with each other. So
Yeah.
we've also got someone on here from Raleigh, North Carolina. Fantastic.
Yeah.
So,
I love that.
one of the things that as we said, the Kwanya, the video will be online later in the week, and we'll send that out to all of you. We'll send that link. For the Pathways to Hope conference, what we're going to be doing this year, because we change the program a little bit every year, and that's really kind of designed by our national office. But we're going to focus on challenges of a changing community and
Shameless plug.
shameless plug for race.
Yeah.
Okay. It's really hard to talk when the chat's going on, but so we're going to talk about access to healthcare, access to mental health care, and we're going to have a lot of people there from these providers that Eddie talked about, from behavioral health providers. We're going to have a great keynote this year. We're still finalizing that, but we're very hopeful that we're going to have. And then in the afternoon, we're going to talk about emergency access to mental health care, because we have a great deal of that in the county, but there's a lot of confusion about that. So we hope that everyone's who's on this call, who is local enough to come, will do that. And there's the registration information in the link. But one of the most important parts of it is the interaction with each other that we have. We have faith leaders there. Is that Shiraz, is that you?
Yes.
You want to jump in?
No, you're doing excellent.
Okay. No, it's fine. So that interaction, that community building around these discussions is really important. And with Dr. Eddie's, our keynote last year, the discussion, as you can imagine, blew up, which is why we wanted to invite him back this year. Eddie, last year you had to leave in a hurry because you had a brisket in the smoker, as I
Oh
recall.
my God, yeah, I was getting used to that was the yeah, I had just bought a smoker, or my wife got me one. I was burning with Wi-Fi connections. I could check. I was checking on the smoker during the
Yeah, I
conference.
was checking on the timing of the brisket, but before you left, because you were
Yeah.
there prior to giving your talk. So could you just share a little bit of your experience there and the feedback that you got?
Oh yeah, the feedback was phenomenal. The be prior yeah, before I even went on that stage, oh my goodness, I met Miami-Dade Fire Rescue Chaplain. I met the Pinecrest Police Chief. I met first responders who are really leaders of society. Then the it's very structured, and I walked away with a lot. Like yeah, I'm Dr. Eddie or whatever, but I learned a lot. And so you walk away with a lot of things, and then I think what's most special is that it's inspiring
Yes.
and and everybody gets together and it's great. And the thing I loved most because it was at Florida Memorial University, which is a historically Black college university. When at some point I said God is good, and everybody was like all the time, and I was like, oh damn, I love that. It was amazing. I was this is the
We
best.
had a lot of call and response
We
going
went to
on.
church.
Yeah, it was
This
amazing.
year we're going to be at the Little Haiti Cultural Arts Center. So, but we always encourage that kind of interaction. Okay, so from Cecilia, I've started mental wellness ministry in my church recently. This was so helpful to reinforce the need for spirituality and prayer. So Cecilia, we hope to see you at Pathways to Hope. We hope to see everyone. If you can't make it, please feel free to reach out to myself or Shara. Great. I was just going to ask you to do that. Shara Johnson, just put her name. We will come to you with presentations and information. We'll come to your faith community and we're going to go a minute over. Shara, do you want to talk a little bit about Compartiendo Esperanza and sharing hope?
Absolutely. So sharing hope is a piece where culturally you sit and you have a conversation about mental health, because many times people do not feel comfortable about talking about their mental health. But when they approach it from a standpoint of how they were raised, whether my family discusses it or not, that is what sharing hope is. We have it for the African American diaspora communities. We have it for the Haitian communities, the Hispanic communities, where you come in a setting with people of like minds and you say, hey, in my family, we don't talk about mental health. The stigma is still there. Or you can say, hey, I've been to some engagements now with NAMI. I'm going to give NAMI a plug. And we are breaking that stigma. So in those conversations, you get to learn and understand the warning signs of mental illness and what to do, because many times people tell you what they are, but what do you do afterwards when you're in a crisis? Do you have those resources? Do you know the resources in your communities and neighborhood? So sharing hope is a smaller portion of what we're going to do at Pathways to Hope. We actually have a sharing hope component this Saturday at the picnic in Rolling Oaks Park, and again in North Miami Beach with Tiffany in the Little Haiti community. So connect with me and I can get you these resources, especially with our Faith Net communities. I'm really trying to expand in our Faith Net communities, and it does not matter your denomination. We need people to know the resources are here. We need to educate and train you, especially as a former teacher. This is so needed, and I'm willing to help from Miami Gardens all the way to Monroe County. Call me up.
So, so thanks, Shara. I don't know if there's a pathways in Sarasota. I don't know. Not every NAMI participates in this. But for us, it's our 5th year. So I'm not sure about that. I apologize. And I also just want to thank Sophia on our team for she's done our Zoom producing, our chat. She did the video. So thank you so much, Sophia, and the rest of the NAMI team. And Dr. Eddie, thank you so much. We really appreciate it.
Thank you, everyone.
I think we've had record attendance this evening because anyone who wants to join the Dr. Eddie fan club, we'll send the link out.
Okay, sounds good. Sounds
Okay.
good. Thank you all.
All right. Thanks, everyone.
I'll see y'all later.
Bye.